Hi, everyone. Good evening. Thank you so much for joining us. Our apologies, we're getting started a little bit later this evening, but we're so excited to have Dr. Maitland with us to talk about mast cell activation disorder this evening. We're going to go ahead and get started with the webinar. So good evening and welcome to tonight's webinar. This evening, we are joined by Dr. Ann Maitland, who will be discussing mast cell activation disorder as a co-occurring condition with primary immunodeficiency. My name is Emma Mertens, and I'm the Program Manager of Community Health at the Immune Deficiency Foundation. On behalf of the Foundation, we thank you so much for tuning in. Tonight's webinar is one of many virtual education opportunities available in our 2023 programmatic lineup. We recognize that through the provision of timely, comprehensive, and accessible information, we can improve the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency. We appreciate you being a part of this journey. Before we get started, I would like to point out a few tech pointers to keep in mind for tonight's program. This evening, we are using the Zoom webinar feature, and attendees should be able to see the slides and hear our presenter and host speak. Attendees will not be able to activate their video camera or their microphone. There will be the opportunity for questions after the presentation. You are welcome to submit any questions you have for Dr. Maitland as you think of them throughout the session. We kindly ask that questions are relevant to tonight's webinar topic. Please type them once in the Q&A box in the control panel on your screen. Please do not include any personal health information, as all questions will be anonymous and read aloud. A brief disclaimer. Please remember the information presented during this meeting is not intended to be a substitute for medical advice, diagnosis, or treatment. We are here today as a trusted source and friend to provide you with information. Always seek the advice of your physician or other qualified health provider with questions concerning a medical condition. Never disregard professional medical advice or delay seeking it based on information presented during an educational event. Be sure to check out our website at www.primaryimmune.org, where you'll find resources, events, support services, and more. Everything is free to access and print. We can also help you find an immunologist or PI specialist in your area with the Clinician Finder tool. The Immune Deficiency Foundation hosts educational programming and events, including lunch and learns and webinars, which cover a variety of topics facing the PI community. We also offer Get Connected groups, peer support, Ask IDF, and our annual PI conference. Applications are now open for the Immune Deficiency Foundation's Research Grant Program. This initiative supports well-defined research projects with a specified benefit for improving the treatment, health, disease management, or diagnosis of people with primary immunodeficiencies. Researchers may apply for up to $50,000 for 1 year towards their specific project. Applications are due by February 29th, 2024. Visit the link at the bottom of the slide to apply and learn more. This meeting is made possible by our wonderful sponsors. It is due to their partnerships and contributions that we can provide programs like this for the PI community. Please join me in thanking our 2023 sponsors: CSL Behring, Grifols, Takeda, ADMA Biologics, Horizon Therapeutics, Kedrion Biopharma, Octapharma, Pharming Healthcare, and X-4 Pharmaceuticals. And now I am so pleased to introduce our presenter for this evening. Dr. Ann Maitland is an allergy and immunology specialist with the Metro-Dora Institute, whose focus is treating complex chronic conditions from a multidisciplinary approach. Prior to joining Metro-Dora, Dr. Maitland served as the Medical Director of Comprehensive Allergy and Immunology in New York and Assistant Professor of Medicine, Allergy, and Clinical Immunology at the Icahn School of Medicine at Mount Sinai. Dr. Maitland is one of the country's top experts in immune-mediated disorders, including mast cell activation. We're thrilled to have her join us this evening. Welcome, Dr. Maitland.
Good evening, everyone, and thank you for that wonderful introduction and invitation. Considering Charlotte Cunningham Reynolds is one of my mentors, I've been very fortunate to have wonderful exposures to how the immune system is misbehaving in our modern era. So let me see if I can start. Perfect. So we're going to talk about mast cell activation and how this leads to aberrant release of chemical mediators in the setting of individuals that have more than likely undiagnosed immunodeficiency syndromes. These are my conflicts of interest. I'm a consultant and on the Speakers Bureau for Blueprint Medicines. I've authored books for disjointed transforming Ehlers-Danlos syndrome and National Academy of Sciences, Engineering and Medicine, heritable disorders of connective tissue, all volunteer efforts of my part. And so we're going to talk about mast cell activation in health, and then the recognition of mast cell activation in common disorders, noting that within the past 10 years, 1 out of 50 Americans have been treated for anaphylaxis. And the latest report from the CDC is 1 out of 3 Americans have 1 positive allergy test. But what's really interesting, in many ways, mast cells are acting kind of like the engine light on your car, saying something's wrong underneath, whether you're hiving, coughing, having brain fog, or joint issues. And trying to understand why the mast cells are misbehaving is what led me to understand that individuals with immunodeficiency, it is a hypersensitivity disorder that pointed me the way of them having an unidentified primary immunodeficiency. So just a brief history of mast cells. They were first identified, interestingly enough, in frogs in the mid-1800s. And you can see there are lots of different things that are identified regarding mast cells and allergy. But really, we didn't know what these cells did until 1989. Oops. And I actually entered medical school in 1989. And at that time, this was the first report that actually gave allergists ammunition to say what we're seeing when we're skin testing individuals or challenging them with either airborne or foods is actually a biological basis. And that led to the relationship between mast cells and one form of allergy in form of allergen-driven mast cell activation disease. But for the next 20 years, basically, because of this observation in 1989, most allergy immunology specialists have a tendency to, and actually most medical professionals have a tendency to focus on the roles of mast cells in Ig-mediated disease. And it's hard to think about the fact that mast cells might be able to release these chemicals inappropriately, especially in the context of immunodeficiency. So when I first learned about mast cells, literally what I was taught is anybody who's presenting with nasal congestion, rashes, headaches, gastrointestinal upset, neurocognitive impairment, fatigue, or brain fog, I was taught to allergy test. So you can either do skin testing, like you see with this gentleman's arms, or you can actually order several different types of allergen-specific IgE through commercial lab tests, Quest, LabCorp, Mayo. And that can give you an idea of at least one way mast cells might be misbehaving. And if somebody was still reacting, but allergy testing was completely negative, whether it's skin testing or through blood testing, we were taught to look for a very rare disease called systemic mastocytosis, which affects maybe 1 out of 32,000 Americans. And to the left is one gentleman that I had the pleasure of participating in his care when I was training in Boston. And to the right was a little boy who came to me when he was about 2 years old, who was actually born with a form of mastocytosis called cutaneous mastocytosis urticaria pigmentosa. And I have to tell you, only within the past few years do we have actually rigorous diagnostic criteria to lead to this identification of this clonal mast cell disease. So essentially, over the past 25 years, when it comes to education about mast cells, it was 2 to 3 medical school lectures, nothing in residency training. Medical specialty training, especially in allergy immunology, just focused on allergy testing or identifying systemic mastocytosis. And essentially, that's where most of the education for mast cells kind of halted, except for maybe about 10 years ago. So what started to happen is a lot of patients, as well as practitioners, were identifying that mast cells can release these chemicals inappropriately for reasons other than going through the allergy receptor, the IgE receptor, or through having a broken receptor in the form of systemic mastocytosis. And I just want to go through how I came to think about the possibility of other syndromes, especially immunodeficiency syndromes, that may be contributing to mast cell disease, such as recurrent hives, or recurrent asthma exacerbations, susceptibility to anaphylaxis, or food intolerances that had nothing to do with having a positive allergy test, either through skin testing or through blood testing, or not able to identify any form of a clonal mast cell disease like systemic mastocytosis. So let's start off with quote unquote skin allergies, which when you hear the term allergies, it's allergen-driven mast cell activation disease, but that's a mouthful. So it's easier just to say that this is allergen-driven skin disease or skin allergies. And again, we have a tendency, if someone is having recurrent itchy red hives or swelling, we'll do environmental testing for pollen, mold, animal dander, components of dust, or we'll do food allergy testing. And again, it's very easy. Most allergists will prefer the upper panel, but any practitioner can order the blood tests. But understand that I can go out right now and test 100 people for instance, IgE to peanut. I'll get 100 people who have, I'll get 15 of those individuals that were tested that will have a positive test. And only 5 of the 15 will say, I actually can't eat peanuts. So having a positive test does not guarantee that you're actually symptomatic from that antibody that is running around. It's no different than we see individuals who run around with autoantibodies such as ANA. It's around, but it's not really causing problems. So in addition to learning about allergy testing, we also learned that there are a lot of different non-allergic triggers. And that's actually how most allergists thought about skin mast cell activation disease or urticarian angioedema is, well, do I find allergies or not? And so in addition to doing allergy testing, and if that was uninformative or not really giving us an idea why this person keep on suffering with this recurrent itchy rash, I would tell them 15, 20 years ago, I'm going to go I'll do some testing. I hope I don't find anything, because typically it means that you have another serious chronic condition, whether you might have a chronic infection like hepatitis, you might have immunodeficiency, like you're lacking complement or antibodies. You might have an autoimmune thyroid disease like Graves' disease or Hashimoto's. I've actually identified at least 2 individuals who had a form of lymphoproliferative disease or cancer, simply because they kept on having an itchy rash. So in many ways, again, if your skin is acting up and allergy testing is uninformative, it's important to kind of dig a little bit more, but you want to make the person comfortable with medications that actually have a very good safety profile, such as histamine blockers or leukotriene blockers. And interestingly enough, the panel on the lower right is a young lady who actually has a physical trigger of mast cell activation chemicals in the skin. And this is someone who actually has cold-induced urticaria. And through the years, there's been several physical triggers that are known to cause people to have increased chemical release. Typically, it can be in the skin, it can be in the airways in the form of nasal congestion or asthma exacerbations. Some people even have neurocognitive changes or cluster headaches due to physical changes. Like some people can actually predict a change in the climate because their joints hurt, or they might end up having a migraine because or more brain fog simply because there's a change in the climate, or they look up at the sun. This is a physical trigger, meaning there's something about the nerves that don't like that change in the environment, that the mast cells then release these chemicals and let you know something is wrong that the body doesn't like. I wanted to show you that over the past, I would say 10 years, we're starting to get more information about other receptors that are responsible for causing mast cells to inappropriately release these chemicals. This is a paper that was done about 8 or 9 years ago, showing that this is an autosomal dominant rare disease in that family members would have a mutation in a stimulatory receptor on mast cells that would cause them to release and have hives and potentially even anaphylaxis due to vibration. And so here you have a nerve perception of a change that the body is thought to be in danger, and then the mast cells then release those chemicals because it's a false alarm. Just want to give you an idea what mast cells look like, because we kind of think about it in an abstract sense. But mast cells, again, are found in lots of different animals and are found in every part of our body. And essentially, they have a job to do. And in my opinion, have been misprofiled as dangerous cells. But literally, what they're trying to do is let you know that something's come into you that they think are dangerous. They're trying to contain it, and sometimes they're going to call in help. So a resting mast cell it's just usually isolated and sitting by themselves, as opposed to a mast cell that's been triggered to release its chemicals. They start to spread out. You start to see particulate matter in the area. So it goes to show you that mast cells have the ability to release some very potent chemicals, not only just histamine, but enzymes that can modify connective tissue. It has heparin, or platelet activating factor, so you can clot or bleed. It has the ability to call in other cells that have very potent chemicals like eosinophils and neutrophils. If you're in a riverbed and you're having a worm that's kind of boring into your foot, the mast cell is there to try to contain that parasite and then call in an eosinophil. If it's a bacteria that you breathe into your nose and the mast cell detects the bacteria, the mast cell will release chemicals such as enzymes to kind of fight off that bacterial infection, and at the same time call in neutrophils. So in many ways, mast cells are kind of like the first responder, trying to identify what has changed in the environment that seems to be causing tissue injury. Can I contain the danger, or do I need extra help in order to eliminate the danger? And then after the harm is contained, mast cells play a key role in tissue repair and healing. I wanted to also show you that mast cells are also very involved in asthma exacerbations. And this is an article by Sally Wenzel, who's been very involved with asthma throughout the years. And she wanted to point out that there are plenty of allergic and non-allergic triggers that can cause someone to have respiratory distress. This focuses on the lower airway, but I can say for the same thing for the upper airway. You have internal changes like increase of estrogen and progesterone, or dropping off of cortisol that may cause you to have increased nasal congestion or lower airway congestion develop. You have exercise, which is a physical trigger. You have susceptibility to infections, including viral or bacterial, and especially with the coronavirus that we've been dealing with for the past several years. And then you have environmental chemicals, whether indoor or outdoor pollution, that can cause tissue injury. And because there's tissue injury, mast cells will be called into action. Hopefully they're able to recognize an appropriate target and then potentially call in help depending on what the danger is perceived. And this is just emphasizing the fact that mast cells work upfront, detect injury, try to contain the injury, call in appropriate help in the form of loosening up the blood vessels so there's leakage of not only cells, but proteins such as complement and antibodies, and then try to contain the danger. And then what happens is if this keeps on happening, you end up with scarring or remodeling of the tissue because the danger never goes away, or the mast cell has lost tolerance and continues to recruit in more inflammation because it perceives that there's a danger going on. And then the last hypersensitivity disorder that I want to talk about is anaphylaxis. And I just want to redefine anaphylaxis. It basically talks about the fact that you had a point of entry of some substance or some change that your body didn't like, and it ended up to be a whole body-wide reaction. And in many ways, anaphylaxis I often treat like earthquakes. You can have a 1.2. For instance, somebody gets an allergy shot in their arm, and then they start to, excuse me, clear their throat like I just did, or they start to have tingling in their hands or feet. Then you have a much more severe form of this hypersensitivity event, such that you start to drop your blood pressure, you start vomiting, you start to have respiratory distress, and that's a much more serious form of anaphylaxis. And unfortunately, literally, this was considered a rare disease when I first entered medical school, and 30 years later, this is now considered 1 out of 50 Americans have been treated for anaphylaxis. And the triggers can be anything from susceptibility to infections to chemicals that you're taking to control autoimmune diseases, antibiotics, foods. Unfortunately, we're seeing individuals that are just more sensitive to our modern world, and the manifestation is in the form of hypersensitivity disorders such as mast cell activation disease. And this is one I just wanted to emphasize, the different things that we can see happen when mast cells start releasing chemicals, very potent chemicals, inappropriately. You can have lip swelling like you see on this child. You can have these migrating hives. You can have gastrointestinal distress or respiratory distress. Some people even describe an impending sense of doom, or they can't think clearly. And so it all depends on where the mast cells have detected danger, quote unquote, and then start releasing chemicals that change the blood flow, start altering the local environment, and then potentially calling other cells that can cause a much more system-wide impact. And again, I just wanted to show you that this is an article from the New England Journal of Medicine back in 1991. And in this, they said this was a rare event. And now, like I said, we have patients who have to carry 2 EpiPens, children that have to have EpiPens at school and at home, simply because the mast cells have lost tolerance to our surrounding environment and now are releasing chemicals inappropriately, even in the setting of potentially lacking other proteins or cells in the immune system, and the mast cells seem to be stepping in as backup. I often compare mast cells participating in a infectious process as like a police officer who shows up to a fire. It's lovely that the police officer is there and may be able to try to offer some assistance, but does not have the skills to actually put out the fire. In many ways, if you have an immunodeficiency, like you're lacking an antibody that can recognize bacteria or viruses, or you're lacking a component in your lymphocyte compartment or complement, mast cells will not stand down. Their job as a first responder is to back up whatever danger and try to contain it to their best of ability. And once that danger is under control, the mast cells will stand down. So one important receptor that I learned about just a few years ago, and I'm just going to call it the MERG receptor for short, but this is important to know if you have an immunodeficiency and you have a tendency to have problems with anesthetic agents when having a procedure or an operation, or there's certain medications that are used for treating certain antibiotics, certain infections such as vancomycin, it is the MERG receptor that is responsible for causing the sensitivity to fluoroquinolones, certain anesthetic agents used during operative procedures. And there's a variability in this receptor. So it doesn't happen to everyone, but it seems that as we better understand how this receptor is different from person to person, we may have a better idea of preventing individuals from having hypersensitivity of mast cell activation events in the setting of procedures or being treated for certain infections, such as vancomycin for instance, Clostridium difficile colitis infections. I just wanted to show you the different antibiotics and agents that are known to tickle this MERG receptor. And if you have a tendency to have hypersensitivity reactions, you should have an action plan that you can take to the provider, whether it's an anesthesiologist or a surgeon or a dentist or a radiologist who wants to do a procedure. There should be a protocol to avoid certain agents that may cause that MERG receptor to cause mast cells to release chemicals, and also to consider using alternative agents, because when it comes to mast cell disease, an ounce of prevention, meaning avoidance of things that might cause you to feel unwell during a procedure or a treatment for another process, is much better to use agents that are less likely to tickle the mast cells. And I could say the same thing for opioid receptors that are on mast cells as well. So if you have a chronic pain syndrome, it's important to identify analgesic agents that have a less likely to cause mast cells to release chemicals, because now the mast cells are going to irritate the nerves, and the nerves are already irritated. That's why you're taking pain medication in the first place. So in many ways, if you're having a chronic condition, it's really important to understand whether or not your mast cells are doing their job or they're doing it inappropriately. There's no getting rid of mast cells unless you have a clonal mast cell disease, such as systemic mastocytosis. The idea is to understand your mast cells are releasing these chemicals, causing you to have chronic issues, whether it's in your nose or your lungs or your skin or your gut or your bladder or your brain. And then if you can identify why the mast cells are misbehaving, you can then have better tailored therapeutics to help you feel better. And I just wanted to point out that when we talk about anaphylaxis, we always seem to link mast cells to anaphylaxis, but this is an article by Mariana Castells, who points out that Not only mast cells are responsible for causing anaphylactic events, but basophils, which is the blood-borne cousin of mast cells. We have individuals that are receiving chemotherapeutic agents for cancer, for instance, or arthritic conditions, and mast cells don't have anything to do with this. This is a T cell macrophage monocyte issue. So again, it's really important to understand there are individuals that have mast cell activation disease, but don't have anaphylaxis. There are individuals that have anaphylaxis that don't have mast cell activation disease. And I know this sounds like alphabet soup, but it's really important to understand that your immune system has overlapping compensatory mechanisms to protect you from the sea of things that come at you every time you breathe, every time you swallow, every time you put something on your skin. Your body has to deem safe or not safe. And if it's not safe, the mast cells and other cell populations have the tendency to go after this inappropriately and cause tissue damage as a bystander on trying to quote unquote help you. So I would say about 2010, 2011, this is after I had been in private practice with a multi-specialty group. If I remember correctly, one of the practice managers at Mount Sinai asked me if I had placed 50,000 tests on individuals in the past year. And I said, that's probably so. But in the setting of doing so much allergy testing, that's when I started to discover that individuals were having reactions in allergy testing, nor systemic mastocytosis was explaining it. And so in 2011, the World Health Organization Mast Cell Disease Committee decided to put forth a different definition to understand if someone's having allergic hypersensitivity-like reactions. Is it the mast cells? And then if you decide that it's the mast cells, you need to figure out, is this broken mast cells that are causing this? Or is there something driving the mast cells to inappropriately release these chemicals? So this was put forth on our national journal just a few years ago, where it's a simple formula, believe it or not, to see whether or not, quote unquote, your mast cells are breaking bad. But it's, do you have signs or symptoms of mast cells misbehaving in at least 2 organ systems? So are you having nasal congestion and headache disorders? Are you having skin reactions and gastrointestinal upset? You just need 2. Otherwise, you're talking about an isolated mast cell disease or possibly another process. Now, after you've identified the fact that you have at least 2 organ systems that are impacted in order to secure the diagnosis of mast cell activation syndrome, you want to know, can you detect any substances that point to the mast cells as the culprit in this recurrent or chronic hypersensitivity issue? And then lastly, if you use medications that tell the mast cells to be quiet and don't secrete these substances, or you give it up with medications that actually block the action of these cells, of these chemicals that get released by activated mast cells, such as histamine blockers or leukotriene antagonists, then the diagnosis of mast cell activation syndrome, a subset of mast cell activation disorders, is appropriate. To go into more details, here it is. Different signs or symptoms of isolated mast cell activation disorders. Mast cell activation disorder of the skin, you're hiving, you're itching, you're flushing. Mast cell activation disease in the joints, you're having swelling or recurrent joint pain or loss of function. In the urinary tract, I can tell you in the United Kingdom, they diagnose individuals that have interstitial cystitis or bladder pain syndrome simply by biopsying the bladder wall and seeing whether or not it's chock full of activated mast cells. What does mast cell activation disease look like in the gastrointestinal tract? You're having bloating, alternating diarrhea and constipation. You're having malnutrition, or you're losing weight, or recurrent reflux or heartburn. What if it's affecting your heart or your blood vessels? We have people who have sudden rates of arrhythmias, or they'll have chest pain or low blood pressure. What does it look like if your mast cells are misbehaving in your brain or your spinal cord? You can have pain syndromes, neurocognitive impairment, also known as brain fog. You can have recurrent headache disorders. And then you have the upper airway, which never gets any attention, but mast cell disease of the nose and the back of the throat, nasal congestion, recurrent postnasal drip, itchiness or fullness in the ears or the eyes. This is all mast cells releasing chemicals that are impacting your upper airway and possibly your eyes as well. So if you check off 2 of those things, next question is, did you try any of these over-the-counter medications and did it give you some relief? Such as, plenty of over-the-counter histamine blockers, such as loratadine or fexofenadine, or H2 blockers, typically used for heartburn, but also very effective for individuals that have mast activation disease, such as famotidine or cimetidine. You have mast cell stabilizers, such as ketotifen, which is readily available, interestingly enough, over the counter as an eye drop. And then you have some prescription medications, such as cromolyn or omalizumab, which is an injectable anti-IgE molecule that is able to help individuals that have recurrent urticaria or persistent asthma with an allergic component. And so now you have a good story. Here are your signs and symptoms. Here are things that you've tried in the past that seem to give you some modest temporary relief. What data do you have? And I think this is probably the most controversial. Unfortunately, we live in a healthcare system where data precedes your story. So it's really important to try to identify a practitioner who allows you to be seen and heard regarding the medical odyssey that you've been dealing with up to this point in time. And I have to tell you, I've identified at least more than a few individuals that have immunodeficiency syndrome simply because they're presenting with symptoms that are just depicted in the cartoon on the left. So with those stories, it's important to understand these are the markers that are associated with mast cell activation syndrome. Mast cells release lots of different chemicals, but if you want to focus on the component of causing hypersensitivity issues, so then we can then identify better therapies for you, you want to see a recurrent tryptase that's elevated or goes up and comes back down. You have surrogate markers such as elevated methylhistamine, prostaglandins in the urine, but the gold standard for diagnosing misbehaving mast cells is the tissue. There are some mast cell progenitor cells in the blood, but the majority of mast cells are found in the tissue. And you need to look into the tissue, skin biopsy. If you've undergone an endoscopy and a colonoscopy by a gastroenterologist, you want to stain that tissue for stains that will light up the mast cells, because if you don't ask, you won't see them. And then instead of just counting them, you want to say, are they overactivated? Are they upregulating activation markers all the time? Because having a mast cell chronically activated is kind of like a police officer who just got out of a firefight and didn't put their gun back in the holster because they're just so revved up. You don't want to see CD25 elevated on mast cells in its site of active inflammation, which unless there was a reason, there's some type of injury that mast cell is trying to address. So you secured the diagnosis of mast cell activation syndrome. You have 2 signs and symptoms impacting 2 organ systems. You get better with medications that either target the mast cells or chemical mediators such as histamine or leukotrienes that are released by the mast cells. And you have test results such as an elevated tryptase or elevated 24-hour urine collection for the prostaglandin or methylhistamine metabolites. Then you want to find out, why are your mast cells misbehaving? Are you the fortunate one that has gotten the genetic lottery luck of having a broken mast cell, such as in systemic mastocytosis, or monoclonal mast cell activation syndrome? These are individuals that seem to have a clonal mast cell problem, but haven't met the full criteria for mastocytosis. But I have to tell you, the majority of patients that come through my practice, if I'm able to identify dysfunctional mast cell compartments, it's likely due to the fact that the mast cells are being driven to release those chemicals by other processes. The one we're most familiar with is, allergen-driven mast cell disease. You have positive allergy tests to foods, medications, stinging insects, latex. But there are other things that can cause mast cells to release those chemicals inappropriately, because there are other receptors that the mast cells use to kind of do surveillance of the tissue to see, is everything copacetic and quiet and at peace? Or is there some type of danger or impending danger that's coming to that tissue that will cause damage? Mast cells' job, again, is I use the receptors to see what's going on in the surrounding environment. I'm seeing whether or not I can detect tissue injury and then determine what is doing the injurious event. And then after that, can I contain it with these other chemicals, such like tryptase and chymase, or do I need to call in help by releasing chemicals that will call in eosinophils and neutrophils, depending on what I'm seeing? We're also starting to appreciate the regular crosstalk between the nerves. So the fact that several individuals suffer from inducible physical urticarias, for instance, such as individuals that have recurrent cold-induced hives, or they look up at the sun and they start to sneeze, or their eyes water, or you have someone who goes into cold water and comes out, and that causes them to hive. So there's miscommunication between the somatosensory neural network and the mast cells that raises that danger signal, and then the mast cells will release chemicals. And then, like any other cell in the body, the mast cells can be a victim of an autoimmune process. This was identified over 2 decades ago, where people who had their serum taken from one part of their body, injected into the other, and it caused a hive and wheal to develop. And that's called chronic immune urticaria, but can be impacting other organ systems as well. So you have the diagnosis. You may have figured out what is causing the mast cells to inappropriately releasing those chemicals. Let's move over to what kind of therapies are available. Oh, I did want to bring up this identification. So this was put forth by Dr. Lyons and Milner when Dr. Milner, who was at a major division at the NIAID, they were looking for the genetic basis for allergies. And what they found was they found individuals, families, that would have an elevated level of this enzyme that's only found in mast cells called tryptase. And what was really interesting, it was a autosomal dominant process, and it was found to be associated with mast cell activation disease, connective tissue changes reminiscent of hypermobile Ehlers-Danlos syndrome or hypermobile spectrum disorder, as well as autonomic dysfunction such as POTS. So again, it points to this communication between the mast cells and the nerves in the connective tissue. And one of the communicators between the nerves and the mast cells I'd like to point out that has really gained traction in the neurology world is the medications that target CGRP. So you have a lot of these migraine medications that are now being routinely used that interrupt the communication between the mast cells and nerves in order to get their migraine headaches under control. But as I said before, I learned about allergies or allergen-driven mast cell activation disease, where for some reason you've developed an IgE that was normally used to recognize parasites with our forefathers and mothers living in areas where parasite burdens were high. And then this antibody now recognizes harmless substances like airborne pollen or milk or a stinging insect. And then you have a release of all these different chemicals. I just wanted to point out there are lots of other receptors on the mast cells that can cause chemical release. And this is also to emphasize that sometimes it's not just the mast cell or basophil that's participating in these hypersensitivity reactions. You have crosstalk between other cell populations. And I have to tell you, in the few years that I've been in my private practice trying to evaluate whether or not people have mast cell activation syndrome, we've identified over 24 patients that have idiopathic CD4 lymphocytopenia coming in for an evaluation for possible mast cell activation disease. We've identified complement deficiencies. We've identified antibody deficiencies. Again, this is how mast cells kind of see the world in their microenvironment, whether they've been assigned to the brain or to the gut or to the skin. And depending on the detection of danger and then the detection of a potential entity that's causing that danger, the mast cells will release those chemicals. And unfortunately, we've seen a huge increase in the amount of mast cell activation disease, especially secondary mast cell activation disease. And I'm going to try to, in a few slides, I'll talk about some of the data we've seen regarding the role of identifying individuals with primary immunodeficiency because they were presenting with more classic allergic-like disease. So I wanted to point out mast cells have a major job to do. They sit right below the surface area of any organ system that's exposed to the environment. So you're talking about the skin and the linings of the gastrointestinal tract, respiratory tract, urodental tract, and they're also uniquely situated right next to blood vessels and nerves. And what they do is they have the ability to detect danger that comes in. They'll release chemicals to try to contain that danger and then call in help. And the way they release the granules, sometimes it's local, but sometimes those granules actually go into the lymphatic system, travel up to lymph nodes, and then call in help. And I just want to point out all the different types of receptors that mast cells have. I originally learned that they had the FC receptor and the KIT receptor. So this is the one that's involved in systemic mastocytosis. This is the one that's involved with allergen-driven mast cell disease, whether or not, again, pollen or food, for instance, or medications. But you can see there are complement receptors, the toll-like receptors. This is a receptor that we think it might be involved in the recognition of viruses, including the one that causes COVID. We have opioid receptors. So in some individuals, when their mast cells are stressed and you add a pain medication, not only will the pain medication not give you any relief, it may actually cause you to have a hypersensitivity reaction and aggravate your illness. We have platelet activating factor. We have this factor, this receptor that can recognize certain antibiotics. So if you have an immunodeficiency and you have a tendency to have hypersensitivity reactions, certain medications that you need to avoid. Here's for when it comes to women going in or out of their menstrual cycle or whether they're pregnant, this can also alter the ability for mast cells to release their chemicals inappropriately. And then you have this crosstalk between other cell populations. You have indirect conversation between B cells based on their production or lack of production of IgG and IgE, for instance, or IgA. And then you also have communication between T cells as well. So when individuals come through my practice, I have a tendency to and usually most patients have had a long medical odyssey of recurrent illness involving multi-organ systems. So I have like a 15-page questionnaire that people fill out, and then I start reviewing what has been done. A lot of individuals have already had allergy testing, and that was not informative. We have people who've undergone endoscopies and colonoscopies, but has not tested for the presence of mast cells being malformed or clustered or overactivated. We have individuals that have undergone evaluations by rheumatologists and neurologists looking for autoantibodies, but autoantibodies are kind of like mugshots for the mast cell. And sometimes you'll make a mugshot with nuclear antigen, which is found in lots of cells, or rheumatoid factor, or your thyroid, or channels on your neurons. And we also know that individuals that have immunodeficiency, interestingly enough, are at increased risk for developing autoimmune disease. So we try to screen for all the different ways mast cells can misbehave. And one that I've been intimately involved with in the past decade is the role of connective tissue disease, heritable disorders of connective tissue leading to mast cell dysfunction. And to the right is a questionnaire where you can actually detect someone who has a connective tissue disorder like Ehlers-Danlos syndrome simply by answering yes to 5 of these conditions that you may have been experiencing within the past 6 months or so. So once you've identified someone that has mast cell activation syndrome or mast cell activation disease, and you've identified why, such that they have, for instance, positive allergy tests, or they're dealing with recurrent infections, or they have an immunodeficiency, depending on what is tickling the mast cells to release those chemicals inappropriately, you then can tailor the therapies based on the positive testing. So for individuals that have allergen-specific IgE, such as pollen or food or medications or stinging insects, you can do allergen desensitization and avoidance measures. You can use medications such as histamine blockade, leukotriene blockade, tricyclic agents, which used to be used very frequently by psychiatrists for mood disorders. But interestingly enough, allergists use it for urticaria/hives. Gastroenterologists use it for quote unquote irritable bowel syndrome, and neurologists use it for migraine. So it's interesting that this tricyclic agents that have the ability to work on the first, second, and third histamine receptors have found a home in other clinical specialties. You have ketotifen and cromolyn, which has the ability to stabilize mast cells from releasing those chemicals inappropriately during degranulation events such as anaphylaxis. And then you also have biologics such as omalizumab. For infections, depending on what you identify, you want to use appropriate antimicrobials, and you might actually have to use something to reduce any hypersensitivity immune responses, such as corticosteroids or leukotriene antagonists, to kind of modify that overactive immune response to an infectious agent. You have individuals that have developed autoantibodies or autoreactive lymphocytes. And so you have anti-inflammatory agents, including immunoglobulin. And then for individuals that have primary immunodeficiency, you have the use of prophylactic antibiotics. I have several patients who, for instance, have recurrent hives and were found to have selective IgA deficiency, and then actually putting them on azithromycin 3 times a week helped get their urticaria under control. And then we also have other anti-inflammatory agents that are available, classically used in higher doses for individuals that have transplant or certain cancers, but in lower doses that have been shown to be effective in reducing recurrent mast cell disease in different organ systems. Just as much as people have the vocabulary of mast cell activation disease, mast cells can be masquerading other conditions. And so it's really important. This is kind of like the unsung fourth criteria for trying to understand whether or not mast cell disease is driving the symptoms or is coming in from another process. So it's really important. And to the left are different medications that can be used for individuals that have mast cell activation disease. I don't want to park somebody on medications if there are other things that are going on. And I have to tell you, in the past few years, we've identified a lot of individuals that have connective tissue issues or have immunodeficiency simply because they're having recurrent urticaria, not well-controlled asthma, neuropsychiatric issues. Actually, there's a growing body of information in the psychiatry world showing that immune dysregulation, even in the setting of secondary mast cell activation disease, is associated with developmental disorders such as ADHD and mood disorders such as anxiety and depression. So this is, again, emphasizing that the unspoken fourth criteria is to make sure that you're not missing any of these other conditions that can look like mast cell activation disease. And I wanted to show you that having one form of mast cell activation disease does not exclude you from another. And this was actually an interesting article that was in the allergy immunology literature, where they are asking a question or giving a review about anaphylaxis and mast cell activation disease. Is it stinging anaphylaxis, mastocytosis, or something else? And the punchline is this was a gentleman who had a history of venom allergy, and that's pathognomonic to allergists if they hear somebody has anaphylaxis to stinging insect and we can't find any IgE. And he was found to have an elevated tryptase of 14. And so, but reactions kept on happening. And so he was actually diagnosed with systemic mastocytosis. He also was diagnosed with the hereditary alpha tryptocemia. So he has 2 primary mast cell diseases, but he also was diagnosed with alpha-gal, meat allergy, and he was also diagnosed with environmental allergies as well as stinging insect allergies. So IgE was detected to cats, and it was also detected to yellow jackets. So this gentleman is looking at several different forms of therapies, including immunotherapy for the stinging insects. He should avoid meat because we have no treatments other than using some of the biologics to keep the mast cells under control. He was on antihistamines and tricyclic agents because he had this clonal mast cell disease, including systemic mastocytosis and hyperalpha-tryptocemia. So just because you secure one diagnosis of why mast cells are misbehaving should not prevent you from looking for other reasons that might cause those mast cells to inappropriately release these chemicals. I wanted to, and this was reiterated by Matthew Hamilton, who's very active in the mast cell world out of Brigham Women's. Unfortunately, when it comes to mast cell activation syndrome, it's not very easy to get a tryptase. Unlike if you go into the emergency department, God forbid that you're having a heart attack, we have lots of different ways for looking to see whether or not your heart is misbehaving. We need more data and testing, validated tests, to identify whether or not somebody's mast cells are misbehaving. But just because we're still trying to elucidate why the mast cells are misbehaving or maybe contributing to a patient's individual illnesses, it's important to make every effort to continue pursuing the possibility of underlying undiagnosed immunodeficiency, for instance, and then also tailor the therapies based on what might be causing your mast cells to misbehave. And I want to emphasize that there are different criteria for mast cell activation syndrome out there. This is from a different group that proposed consensus 2. They they prefer to lean into an overdiagnosis of mast cell activation syndrome. And although it's relatively safe to park people on medications like histamine blockers or leukotriene antagonists, if it's going to prevent you from pursuing other diagnoses that might be causing the mast cells to misbehave, like someone who has an undiagnosed cervical spine injury or somebody who has an undiagnosed immunodeficiency, if you stop at antihistamines that give them modest relief, but not get at the fact that they might have common variable immunodeficiency, which I have identified in several patients, or idiopathic CD4 lymphocytopenia, or a complement deficiency such as mannose binding lectin deficiency, which has been associated. If you have mannose binding lectin deficiency and immunodeficiency, you're at increased risk for requiring gamma globulin replacement to keep your symptoms under control and prevent you from getting ill from major infectious events. So why do people come for an allergy immunology evaluation? It's like, I got MCAS, and my response is maybe. But just because I say maybe doesn't mean I don't think nothing is going on or this is all contrived. It's just that it takes time to kind of peel back all the layers, because for the most part, patients, as we know with primary immunodeficiency, can have an undiagnosed immunodeficiency 6 to 12 years after initial onset of symptoms. I could say the same thing for mast cell activation syndrome, which is a subset of mast cell activation disease. And I wanted to use this 10 warning signs for primary immunodeficiency because this is what both patients and doctors need to be aware. It's not acceptable for you to have a pneumonia every year. It's not acceptable for you to have 4 recurrent sinus infections in a year or not get better when put on prolonged courses of antibiotics, or for you to have sepsis or an abscess, or if you have a family member, interestingly enough, who's already being treated for immunodeficiency. Getting a good story will lead you to appropriate testing, and the appropriate testing will lead to tailored therapies based on what diagnoses you're able to secure to give you guidance. Now, this is the questionnaire that I'm happy to provide this, but this is the questionnaire that I have patients fill out before I see them. And just again, remember the first criteria. Do you have mast cells misbehaving in at least 2 organ systems? And if I see if they check 2 of these organ systems, I know that I need to think a little bit more deeply about the fact that their mast cells are misbehaving. And then once I find out that their mast cells are misbehaving, it's important to identify why those mast cells are misbehaving. Do you have some rogue broken mast cells, such as systemic mastocytosis or hyperalpha-tryptosemia? Or do you have another process that's driving the mast cells to misbehave? Like, do you have POTS? Do you have an immunodeficiency? Do you have an autoimmune disorder? It's important to try to understand why the mast cells, which are educated in the tissue, that guard the tissue in the form of surveillance with the different markers, that the mast cells in many ways are trying to compensate, especially in individuals that have immunodeficiency. They might be compensating for those missing components that are important to contain the plethora of microbiota. Some of them are friendly, some of them are not, and some of them are squatters. And it's the squatters that have a tendency to keep on causing injury in our GI lining or our respiratory tract that might be recruiting mast cells and other components of the immune system and contributing to chronic injury and inflammation in affected organ systems. So this was an article that came out just a few years ago. Doctor, I think I'm suffering from MCAS. Again, this is just a reminder of the checklist to try to consider whether you have mast cell activation disease, even if you already have a diagnosis of immunodeficiency. Do you still have signs or symptoms of not well-controlled nasal congestion, gastrointestinal distress, brain fog? And actually, we're starting to see a role of the immune system, even in the form of the innate immune system, such as mast cells, in contributing to long COVID. Do you get better with medications that target the mast cell compartment? And then, what data do you have to support it? So I wanted to kind of just briefly go into some of the observations that we have reported in the private practices that I've worked in. And some of that led me to even think about autoimmune immunodeficiencies in people who were thinking that they were having allergies or mast cell activation disease. This is a paper showing that individuals that have selective IgA deficiency are at increased risk for chronic urticaria, and also autoimmune diseases. And then the 10 warning signs of primary immunodeficiency, which we just reviewed, they're showing that if you have allergies, for instance, or allergen-driven mast cell disease, it's as though your mast cells are so preoccupied with innocent substances like pollen or animal dander that they completely ignore the bacteria that's hiding in the tonsils or sitting in the gastrointestinal lining, waiting for an opportunity to get in. So in some ways, having an allergen-driven mast cell disease can make you susceptible or cause you to have a immunodeficient condition. And this is a paper from David Kahn, who's the past president for the American College of Asthma, Allergy, and Immunology. And he's saying, okay, we have individuals that have refractory urticaria or refractory asthma. It's interesting enough that one of the agents that's used for recalcitrant chronic urticaria, which is basically mast cell activation disease of the skin, is immunoglobulin. So if omalizumab doesn't work, immunoglobulin has been used successfully, and also, again, prophylactic antibiotics. This is a paper that I had done with two lovely individuals in my practice, Isabel Brock and Walter Prendergast, where we did a retrospective analysis of all comers claiming that they had mast cell activation issues. And what we found, interestingly enough, this is over 980 patients came through my practice. 46% had evidence of single organ involvement of mast cell dysfunction. But what was even more concerning is 21% had evidence of mast cell activation disease and immunodeficiency. So 1 out of 5 had some evidence of a deficiency in the antibody compartment, everything from common variable immunodeficiency to normal immunoglobulins, but poor protection against bacteria such as Streptococcus pneumoniae, Haemophilus influenza, as well as IgG subclass deficiencies. And this is simply by taking a really good history and then doing appropriate testing, looking at total immunoglobulin levels, looking at what protection you have against measles, mumps, and rubella, Streptococcus pneumoniae, Haemophilus influenza, just an extra step that then led to better therapies for these patients. This is a very, very busy slide, but I just wanted to show you that this was a study that I had done almost 6 or 7 years ago, where we identified individuals that lacked a protein called mannose-binding lectin, which is part of the complement system. And complement hasn't gotten much attention until lately, but it's interesting to think that this part of your system can not only predispose you to infections, it can also predispose you to ongoing tissue damage because you're not clearing away the injured tissue, and that in turn leads to autoimmune development. And so these are 25 patients who had mannose-binding lectin levels lower than detectable, and they were plagued with neuropsychiatric symptoms, gastrointestinal distress, lower respiratory symptoms, and skin symptoms as well. So when you think about mast cell activation disease, and these are the various, on the right, these are the various syndromes that are associated with mast cell dysfunction: rhinitis or rhinosinusitis in the upper airway, asthma, the lower airway. You have hypersensitivity gastroenteritis, sometimes referred to as irritable bowel syndrome, until you identify something other than idiopathic that might be causing gastrointestinal distress, interstitial cystitis, urticaria, angioedema and flushing, neurocognitive impairment in the form of headache disorders or brain fog, and pain syndromes. That's what most of us have learned what mast cells can do. But I want to take you back to the fact that not a single human lacks mast cells. Mast cells are found in lots of different organisms. They have the capacity to do lots of different things, not only tissue defense, but tissue repair. And they have an intimate relationship with the connective tissue, the blood vessels, and the nerves. They all talk to each other, trying to figure out whether or not this is a safe environment for the body or not. And the mast cells are equipped with different receptors to find out whether this is active or not. And they also have a plethora of chemicals to activate other immune cells, change blood flow, recruit in cells, direct antimicrobial or antiparasitic effects, and then also can cause tissue remodeling. So in many ways, I consider having a mast cell disease, and most of the patients that I've encountered, it's kind of like what you find on your car. Something's wrong, you need to just go looking. That's what I find with urticaria. That's what I find with asthma. That's what I find with gastrointestinal distress and neurocognitive impairment. And it's important, again, to realize that mast cells can misbehave in any organ system. It's important to figure out whether or not they're driving most of the symptoms or they're reacting to another process. Again, this is the criteria. And I just want to be a reminder, I don't have to tell the individuals that are attending this conference that we underestimate how many individuals are impacted by primary immunodeficiency. Jordan Orange, who now heads the Department of Pediatrics at Children's Hospital of New York, has estimated that 1 out of 1,200 individuals have some form of immunodeficiency, whether we're talking issues with the epithelium, the innate immune system, or the adaptive immune system. And with that, I will round up with just gratitude. I'm grateful for IDF for inviting me for this. I've had the pleasure of patients telling me stories that kind of just lifted all the misinformation, or at least the help round out the foundation that I had when I was training and as in private practice. I have phenomenal colleagues that I've had the pleasure of working with. I have to tip my hat to the Mastocytosis Society, Ehlers-Danlos Society, Dysautonomia International, and Chiari Syringomyelia Foundation. And this is my contact information at Mount Sinai. And the building here is Metrodora in Salt Lake City, where we are trying to make new inroads in a collaborative environment to try to tackle complex diseases, including individuals that have immunodeficiency and comorbid connective tissue, as well as mast cell disease.
All right, thank you so much, Dr. Maitland. That was incredible. And I have to say, every time someone would submit a question, your next slide would address the question. So excellent presentation. Thank you so much. All right, everybody. So I know everyone's eager to get into the Q&A, so we're going to transition to that next. A friendly reminder that if you would like to ask anything, to please enter your question in the Q&A box. Dr. Maitland, we're going to skip around a little bit just based on some of the questions being answered on some slides, and then some that I feel apply to more folks in the audience. So, and I also want to let everyone know we do have a large number of folks on the call, which is great, but that does mean that we may not get to every single person's question. We want to be considerate of Dr. Maitland's time. She is with us after hours, so we're going to work through as many Q&A questions as we can, and we appreciate your patience. All right, Dr. Maitland, first question. So this individual asks, they have shared that they have autoimmune chronic urticaria and serum histamine that is too high to measure. They've undergone testing for mastocytosis, which was negative, and they're taking Xolair, which has been helping their symptoms. However, their serum histamine remains above the top of the test's ability to register their actual value. What are your thoughts on that individual situation?
So we've identified several individuals that have an expansion of a different T cell population called gamma delta T cells that seem to be associated with persistent histamine elevation. And gamma delta T cells are very interesting. And if you don't look for those cells, you won't identify them. So that would be my one situation I would identify. And then also, it's important to screen for other disorders that can contribute to that, especially if it's in the setting of, again, undiagnosed immunodeficiency can do that as well. And then we also find individuals that may have cervical spine issues. The vagus talks directly to the mast cell compartment. And if there's any issues with neck pain or central nervous system issues, that can also cause the vagus to be disarmed, which will then allow the fight or flight response to keep persisting. So I would say that further evaluation needs to be employed. I would see whether or not there's an expansion of these gamma delta T cells. I would evaluate for peripheral and central nervous system issues as well.
you, Dr. Maitland. All right, next question. This individual asks, is it possible to have chronic idiopathic urticaria and mast cell activation syndrome concurrently, or are they mutually exclusive?
They overlap. You can have urticaria for reasons other than mast cells, but so far it sounds like you have at least one secondary mast cell disease, in that you have autoantibodies that have not only the ability to recognize mast cells, they also have the ability to recognize basophils. So you have two cell populations that are being tickled. So it overlaps in that mast cells are definitely involved, but understand some of the receptors that are in basophils also are found on mast cells, and mast cells and basophils have the largest collection of histamine in the human body. So it's overlapped, it overlaps, but I would say you have an immediate hypersensitivity disorder in the setting of having another immune system drive the mast cells to release those chemicals.
Thank you. All right, next question. Is anaphylaxis required for a mast cell activation syndrome diagnosis?
Absolutely not. So literally, it's two organ systems. So if you have anaphylaxis, by definition, that's multi-organ system involvement. But we have individuals that have anaphylaxis and mast cells are not involved. And then we also have individuals that have mast cell activation syndrome and anaphylaxis is not on the table. So either way, it just tells me your immune system is in overdrive inappropriately, and you need to figure out why your mast cells are misbehaving or why you're susceptible to anaphylaxis.
Thank you. Next question. What evidence is there for associating mast cell activation syndrome as a source or etiology of brain fog or migraine?
Great question. So there was a great paper that just came out of Brigham and Women's. It was a joint effort. And again, I emphasize joint effort between allergy immunology and neurology. And they show that if you have a pre-existing neurological issue, right, if you have mast cells that are susceptible to being twitchy for whatever reasons, releasing histamine and other factors that loosen up the blood vessels will drop your blood pressure and and actually even drop the blood pressure in the cerebral vasculature, and that will exacerbate your brain fog. We also know that mast cells, the more they're activated, the closer they move to the nerves and the mast cell and the blood vessels. And so the more you tickle the mast cells, it's kind of like you keep on calling 911 and the police keep on coming. And after a while, they might just station you right there. That's what seems to be happening. Also, there is direct communication between the mast cells and the nerves. So for instance, you have these new migraine medications, and you have to forgive me, I don't know their generic names, but Ubrelvy is one, Ajovy is another. Those are all anti-CGRP antagonists, and the CGRP directly communicates between the nerves and the mast cells. So here you have a medication that targets a chemical from the nerves that keeps the mast cells quiet.
Thank you. All right, our next question. I think this is one that probably a lot of folks have on their mind. What are the best lab tests to get to identify mast cell issues?
So I usually, when a patient first comes to my office, I want to see serum tryptase, 24-hour urine collections for methylhistamine and prostaglandins, total serum IG level. I go ahead and also, if they've had endoscopy or colonoscopy, I'd like to see that the pathology there. And a lot of people get those, and that's easy enough. Allergy testing, either skin testing or through blood testing as well. I go ahead, if you've checked off anything regarding the screening test for immunodeficiency, I'll go ahead and do a screening test for immunoglobulin deficiencies, lymphocyte deficiencies, and complement deficiencies as well. So the first set of tests are your mast cells misbehaving? The second set of tests are why they might be misbehaving. And so that's where I would normally start first.
Great answer. All right, next question. We actually had a webinar on this topic last month, so I think it's also top of mind for folks. Can mast cell activation problems cause interstitial lung problems?
Mast cells will respond to any danger. But the issue is the medications that are typically recommended for like anaphylaxis and urticaria really is focusing on a different pathway than will be participating in interstitial lung disease. So you're really talking about tissue remodeling. And so a lot of people think about mast cells and tissue defense, but tissue remodeling. So mast cells have the ability to release VEGF and interleukins and cytokines and growth factors. And if those growth factors are not released in a coordinated fashion or are continually being released along with enzymes that can modify the tissue, then using histamine blockade is going to be useless. Using leukotriene antagonists are going to be useless. So you're going to have to start moving into going after the cells and the chemicals that are known to be more common in interstitial lung disease. I'll give you an example of another, not well-controlled asthma is associated with tissue remodeling. And using histamine blockers and all the medications I talked about regarding allergen-driven mast cell disease or physical triggers of mast cell disease are going to be useless. They might give you some symptomatic relief, but it won't stop the remodeling in the tissue. The ones that have been shown to stop the remodeling in the tissue target some of the cytokines and chemokines that get released by the mast cells, right? So there's mast cell activation disease can be it can be an immediate hypersensitivity issue, can be a tissue remodeling issue, right? But that's going to require a different set of testing to understand what part of the mast cells are misbehaving. Is this too much of a growth factor, too little of a growth factor, too much of an enzyme? And understand the enzymes that mast cells have the ability to deactivate like venom. Anytime you ever have a chance to like look into honey badgers and mast cells, honey badgers actually have tryptase that can deactivate the venom of snakes that they attack. So you don't want those enzymes out there unless you really need them. It's kind of like the police officer. You don't want the police officer to pull the gun out to take the cat out of the tree, right? Because so you don't want those enzymes out there. You don't want heparin out there. You don't want platelet activating factor out there unless you really need it, like puncture wound, infection, cancer cell. That's why you want it out there.
All right, thank you. All right, next question. So these are some individuals sharing kind of their current situations. This individual asks, I was on IgG replacement for 7 years. I identified mast cell activation syndrome, and my body was rejecting many foods as well as medications, including Cuvitru. Is it possible for mast cells to react to plasma infusions?
Yes. And the reason why is when you use, and this is the issue with subcutaneous preparations, period. There are stabilizers in there that may be problematic. And also, when you think about gamma globulin replacement, you have to think about how they obtain it. So it's 20 of your closest neighbors. Then it undergoes filtration, radiation. Just let her know. Radiation, and detergent. And so different companies have different production processes for making their products. So I find that intravenous is a lot better tolerated than subcutaneous. But a lot of insurance companies prefer subcutaneous because it's cheaper to administer to you. So if you're having a problem with a gamma globulin product, you either have to think about how you're administering it or whether you need to consider a different preparation, or maybe you need to move away from subcutaneous and go to IV.
Thank you so much. All right, next question. This one's about food allergies. This individual says, I have many food triggers that cause allergic symptoms, including angioedema or anaphylaxis, but no detectable IgE. Do you know if this is a common scenario?
Yes, actually. There are receptors other than IgE that there are receptors on mast cells other than the ones that recognize IgE. So we know that mast cells have complement receptors, so they can respond to complement. They can respond to IgG. So we have individuals. I've had one patient anaphylaxed to a vaccine years ago. It was pneumovax. And actually, I was so worried about her. I only gave her a quarter of a dose and she still had a minor reaction. And so I think it's important to kind of take a step back and understand that mast cells are not a one-trick pony, right? It's kind of like that police officer that's in your neighborhood. Do you really want him to only determine whether or not somebody is a perpetrator because they have a mugshot? Right? They should be able to have a sense, like, common sense, that person with the gun or the person with the hatchet, or if somebody's down on the ground, you want them to be able to assess danger. And that's what mast cells, that's their job. Their job is to assess danger, contain it, call in help, and then once the danger is contained, help with tissue remodeling. Lots of different receptors. We have women who go in or out of their menstrual cycle, ending up with worse hives and worse asthma. That's an estrogen and progesterone issue on the mast cells. We have individuals that can't tolerate certain medications. That's a MERG receptor issue. And then I have to tell you, I'm surprised that I was able to identify so many different immunodeficiencies simply because people were having food intolerances, medication intolerances, air quality issues, causing them to have respiratory distress. And a lot of them, their IgE was like undetectable. As a matter of fact, they're now starting to look into IgE deficiency, which we don't talk much about because we don't live near the Amazon and have to worry about parasites. But I would lean into the Goldilocks rule for most of the things that are in our body. We don't want too little and we don't want too much.
Thank you so much. All right, next question. This individual asks, for those of us with autoimmunity, allergies, and high norepinephrine in POTS, could the norepinephrine be fueling the mast cell problems?
Actually, epinephrine has a tendency to keep mast cells quiet. I'd be more concerned about why that was happening. And so, again, you want to make sure that there are not other processes going on. So POTS is a general description that just tells me your nerves are misbehaving. There's an imbalance between the rest and digest part and the fight or flight part. And you can either have too little rest and digest or too much fight or flight, or both at the same time. It's kind of like hitting the brake and the accelerator of your car at the same time. That only describes what's going on. It doesn't tell me why it's happening. So did you develop autoantibodies against your neuronal tissue? Do you have cervical spine issues or occult tether cord issues, or do you have an undiagnosed connective tissue issue? There's so many different things that can that can be happening. And unfortunately, because our society, our healthcare system is so siloed, people have a tendency to be camped into one diagnosis and one clinical specialty. And I have to tell you, for instance, mast cell activation syndrome, the first clinical cohort was a joint effort between gastroenterology and allergy immunology. And gastroenterology, this was an IBS clinic, and people were parked in that IBS clinic for 5 to 7 years until they got the diagnosis of mast cell activation syndrome. So I would say that better things need to be addressed.
Certainly, thank you. All right, next question. We have time for just a couple more, Dr. Maitland, if you're okay with that.
Yep, I think I'm getting a call from a patient. I might have to handle a couple more and I have to then go back to
No problem. Just when you need to go, just let me know and we'll wrap things up. We really appreciate it. Okay, we'll do maybe two more. And if you need to go, just let me know. All right. This next question, if PIDs aren't diagnosed and treated until later in life, after decades of frequent infections, is that person more likely to develop autoimmunity and mast cell disease due to foundational immune dysregulation from their untreated PID?
So untreated PID means there's more susceptibility to tissue injury. The more you have tissue injury, the more you're going to have normal tissue, broken normal tissue out there, which your immune system can recognize. So especially when it comes to PID, antibody PIDs, we find that the red blood cells and the platelets end up to be a major target. We see autoimmune disease that happen and thyroid disease that happens as well. So the more you have tissue injury, the more likely you're going to start hurting direct tissue. And by the way, those antibodies that recognize, your thyroid, the business end recognizes mast cells. So, and the same thing for autoimmune disease. There's been a lot of work showing that mast cells may either contribute to the initiation of loss of tolerance in autoimmune disease or perpetuate it. So again, I think it's all about balance. And you want to use your police force when you need it. You don't want the SWAT team being called in when you don't. You don't want eosinophils running around. I mean, they have the ability to release eosinophil-derived neurotoxin. So I don't want tryptase out there unless I really need it. Like if I get a cut, I want tryptase out there. But if I'm just sitting there, reading a book and chomping on an apple, no, I don't want it out there. So it really is all about tolerance, but not well controlled. Having an immunodeficiency tells me you're at increased risk for having not only bad bacteria sit there, but squatters. And typically the respiratory tract and the GI tract are the major targets in that respect. And so that's why we need to intervene early. I'm working with a family right now that the two of the children, one child was diagnosed early with autoimmune encephalitis and was put on gamma globulin. The other child had evidence of recurrent sinus infections before the age of 5 and never got gamma globulin until he was a teenager. And now he's much more susceptible to autoimmune disease. Yeah, he has it. And and here's the thing, it's not just autoimmune disease, it's autoinflammatory syndromes also that get unmasked when you have ongoing tissue disease. Ounce of prevention, it's much better to prevent the fire than to try to put it out.
Certainly. All right, do you have time for one more? Okay, awesome. Thank you so much, Dr. Maitland. All right, I think this is a good tie-in with that last question. Have the PID patients you have treated that also have mast cell disorders have more difficulty tolerating IVIG or sub-Q than patients without a mast cell disorder? If yes, what is the best way to partner with their immunologist to find a treatment that a sensitive mast cell patient can tolerate?
So we have a tendency to onboard gamma globulin slowly. So we'll typically do a quarter dose twice IV. I have to tell you, I don't lean into sub-Q very often. I prefer having a nurse monitor you who's knowledgeable in this space as opposed to what are we going to start doing now? Colonoscopies in aisle 5 of Walmart? I mean, it's crazy. So not to besmirch Walmart. That being said, we have a protocol where we onboard it very slowly. I even do that with Zolder. We go omalizumab, we go very slowly. So, typically I do a quarter dose and we do pre-hydration and pre-medication before and after. We use specialized tubing. We usually go for the expensive tubing that's PVC and DEHP free. And then we work you up to every 3 to 6 weeks, depending on how you're responding to the initial management. And then once you're stable, we'll start expanding the dose, expanding the time between episodes. But onboarding slow and steady wins the race.
I think that's a great approach. Well, thank you so much, Dr. Maitland. That is going to wrap up our Q&A this evening. We are so appreciative of your time and your extremely thorough presentation and taking the time to answer everyone's questions. It was a pleasure having you join us this evening. Thank you so much.
Thank you for the invitation. Everybody stay well and happy Thanksgiving.
Thank you so much. You too.
Bye now.
All right, everybody. So we just have a couple more slides to get through, and then we will wrap things up this evening. All right. So again, a huge thank you to Dr. Maitland for her time this evening. And thank you everyone for your participation and engagement in the Q&A. We really had some great questions and we appreciate you submitting them. If your question was not addressed during our program, go online and submit your question to Ask IDF. Visit primaryimmune.org/ask-IDF, or you can also give us a call at that 800 number on your screen. Our resource navigator will personally connect with you to answer your question or direct you to appropriate resources. You can also check out our resource center, support services, and YouTube page to find more videos and educational materials. As we head into the holiday season, we have a few events left to close out the year, and we hope to see you at one of our upcoming programs. Our final webinar of the year will take place on December 6th, and we will be discussing COVID's impact on the PI community, and our teen holiday hangout will take place the following week on December 12th. Visit primaryimmune.org/events to register and learn more. Registration is open for our 2024 PI conference, which will be hosted in person at the Sheridan Grand Riverwalk, Chicago from June 20th to 22nd, 2024. Visit primaryimmune.org/conference to register today. And scholarships are open for the conference and are available to individuals who have been diagnosed with a PI. Visit the conference landing page to apply by January 5th, 2024, and you can also email events@primaryimmune.org for more information. Thank you again to our wonderful sponsors for their generous support of our programming this evening. And thank you everyone for your participation this evening. A huge thank you again to Dr. Maitland for her time. On behalf of the foundation, we wish everyone a healthy and safe Thanksgiving next week. Take care and have a great rest of your evening.